Hello, everybody, and welcome to our webinar. I think we are going ahead and get started. This is Caroline Fichtenberg from the Social Interventions Research and Evaluation Network. We're very excited today to be hosting a webinar to highlight a special issue of the American Journal of Preventive Medicine that we helped publish last fall, and to discuss key questions for improving social needs interventions research. Just a few housekeeping items to get us started. We are recording this webinar, and both the recording and the slides will be made available on our website next week. You will all get an email letting you know once those are available. So don't worry about taking crazy notes. You'll get the recording and the slides. Also, please submit questions that you have for our panelists in the Q&A box that you see. If you take your cursor to the bottom of your screen, you should see a Q&A box. You can submit substantive questions there. If you have technical questions, go ahead and chat them in to us. Great. So want to highlight and thank the funding that is making this webinar possible, which is from PCORI, although of course any views presented on this webinar do not reflect the views of PCORI. You're going to be hearing today from three of us. This is Caroline, as I mentioned earlier, with Siren at UCSF. You're also going to be hearing from Dawn Alley, who is the Deputy Senior Advisor for Value-Based Transformation in the HHS Office of the Secretary, as well as from Kamala Mistry, who's the Associate Director in the Office of Extramural Research, Education, and Priority Populations at the Agency for Healthcare Research and Quality, or AHRQ. Before we get started, I did want to give those of you who are not familiar with Siren just an overview of what Siren is. We are a national initiative housed at the University of California, San Francisco. Our mission is to improve health and equity by advancing high-quality research on healthcare sector strategies to improve social conditions. We do three main things. We catalyze and conduct high-quality research. We collect and disseminate research findings, and then we also provide evaluation, research, and analytics consultation services. Basically, we're a hub of information about research on social interventions in healthcare, and if you are not familiar with our website, highly encourage you to go to it and view our evidence and resource library and avail yourself of the resources that are there. So today we are going to be talking about a paper that was published as part of a special issue that was in the American Journal of Preventive Medicine, published online last November, that brought together a number of papers specifically on identifying and intervening on social needs in clinical settings. There were 10 papers in the special issue. All of them were really interesting. I'm a little biased, but highly encourage you, if you haven't checked them out, to look at them. And today we're going to be zeroing in on one of them, which was an overview of what we know and what we don't know in the field right now, and specifically with a focus on key questions for advancing the field. Before going into our panel discussion with our two other co-authors on this paper, do want to kind of provide a summary of this paper for those of you who haven't had a chance to look at it. Next slide. Great. All of the work that Siren does is focused on helping researchers catch up with what is happening in the field, in terms of experimentation that is happening in the field. So overall, there has been such an enthusiasm for social interventions in healthcare that we have innovators and early adopters that are racing and experimenting with all sorts of interesting interventions, and researchers are behind, huffing and puffing, trying to catch up. is helpful in thinking about what we know and what we don't know, to think about the theory of change behind these interventions. So the basic theory of change is we want to identify social needs among individuals presenting for care at various parts of the healthcare sector, provide services and or referrals to help address those needs, with the idea being that that will help those social needs improve, which will then help health outcomes improve, which will hopefully reduce unnecessary utilization and reduce costs. But there's also another pathway through which information about social needs can be helpful in the healthcare sector. And this was highlighted in a recent National Academies report published last September. And this other pathway is represented here with the green boxes and arrows. And this is the idea that this information about social needs can also be used to tailor clinical care, to ensure that care is tailored to the needs of individuals and the situations that they're living in, which will improve care quality, which will also hopefully help improve health and reduce unnecessary utilization. The National Academies calls these two pathways, the top one, the assistance pathway, and the bottom one, the adjustment pathway, with the assistance being the idea of assisting patients to address social needs, and adjustment being the idea of adjusting care to take care of patients, to ensure that care is responsive and meets the needs of whole patients. In the paper, we also highlighted that there are other pathways through which social needs interventions could also affect health. And we highlighted a stress pathway. I put it here with question mark because there's still relatively little evidence about whether or not this is truly happening. But the idea of this pathway is that providing services and or referrals, as well as tailoring clinical care, can help reduce the stresses associated with socioeconomic risk, which on its own, even independent of higher quality care and independent of reducing social needs, could also help improve health. And finally, in the paper, we also highlight another pathway, which is the idea that all of these activities happening in the healthcare sector could potentially help reduce provider burnout. There's a fair amount of association studies now linking higher provider burnout to having fewer resources to help address patients' social needs. And we know that providers in safety net settings in particularly suffer from a lot of burnout due to feeling that they are not able to truly address the needs of their patients. So there's a hypothesis that perhaps all of these interventions could also reduce costs in the healthcare system by reducing burnout. So what evidence do we have related to these pathways? Overall, most of the evidence to date relates really to that top pathway. Most of the research that's been done to date is about the impact of providing services and or referrals on social needs as well as health. So we have, starting though back with the screening, there's also a fair amount of evidence on screening itself. And several studies have found high patient acceptability overall for screening, although some patients have concerns, and particularly in pediatric settings where there are concerns around the implications of disclosing social risks, such as housing instability or food instability, and the implications of that in terms of child protective services. But a fair amount of research has accumulated and has continued to accumulate, highlighting that overall there seems to be high patient acceptability. And there's suggestive evidence, a couple of studies so far, that patients may appreciate being asked about social needs even if providers don't offer any assistance. So this relates, so far is evidence suggesting that patients appreciate being asked because it makes them feel that their providers care about them. So it's some evidence may be suggestive of this stress pathway, but also more generally of patients feeling better cared for through these interventions. Another piece of evidence that does seem to be, we're seeing several studies around this, is that self-administered screening does seem to increase disclosure of needs, and we have 2 papers in particular that have highlighted that already. There are lots of gaps still around screening and our understanding of how to best identify social needs. These are just some of them. So there are questions around what screening approaches maximize patient acceptability. There are questions related, and I think a wide-ranging debate about whether or not social needs screening should be standardized, or the extent to which it should be standardized versus how much it should be customized to each specific setting. And there's also some questions around whether screening is needed or should everyone be offered assistance, as research has accumulated documenting that there is not always a great overlap between who screens positive and who wants assistance. In terms of intervention effectiveness, we have a number of studies that are finding benefits. For example, meal delivery programs, there's a number of rigorously designed studies that have found both health and utilization benefits. But the evidence is still relatively sparse, especially compared to how much interest there is in these interventions. Some of the gaps are pretty basic. Do these interventions work? And also, how should we judge whether they work? The recent negative findings in the Camden Coalition randomized controlled trial, some of the discussion, which looked specifically at impact just on hospitalization and admissions, raised the question of whether that's the right metric for looking at these interventions. And there are a lot of folks trying to think about what should be the right outcomes to judge these interventions. Then there are these questions of how these interventions work. As I just highlighted, what are the mechanisms? They may not all be operating through addressing social needs. There are other ways to use the data, and research is needed to identify whether these other mechanisms are operating and if there are others that may be operating as well. There are lots of questions about what the most cost-effective and cost-effective approaches are and for whom and in what contexts. I think it's clear that it's probably not a one-size-fits-all, and we need more research to help identify which approaches work best in which settings. There's a whole set of other questions also around unintended consequences. Unintended consequences both for patients, potentially for care teams, as well as for social service and CBO partners. And there's a little bit of research in that space, but much more is needed. And then finally, I wanted to highlight that there's a central question around impacts on health equity and how they can be maximized that has not yet received enough attention. Ultimately, most of these interventions have as a goal to increase health equity, but very few actually examine impacts on health equity or articulate exactly how these interventions are maximizing health equity impact. So that's another area that is worth highlighting. And then I want to highlight a final big area of research, which is this question around intervention adoption. There is some research increasingly being done around understanding what kind of provider staff training and technology can help increase screening rates and interventions. And we are seeing some studies that are identifying definitely staff training increases comfort with screening and can increase screening. It's also clear that practice settings need a fair amount of support to implement screening. It's not enough to just make it technologically possible, but there's also a need to help support people in developing the workflows and developing the comfort with doing it. Also, community-based organizations are interested but concerned based on some of the research that's been done in that space, and there's a lot more needed to better understand how to maximize partnerships and how to engage CBOs in this work in a way that's a win-win for both healthcare and CBO organizations. So some of the gaps here that are worth highlighting are around the capacity building approaches, which are most effective. How can patient engagement and participation be maximized? There are also a lot of questions around payment and quality incentives, as we're seeing more and more Medicaid agencies have an interest in incentivizing social needs interventions. And then also this question again about how to avoid unintended consequences in the implementation. So to recap, researchers are working hard. They're catching up, albeit slowly, but increasingly quickly. At Siren, we're monitoring the research literature, and every month we're seeing more and more really great research coming out to help answer some of these important questions. I want to turn next to having a conversation amongst the three of us who wrote this paper on the key gaps. So Don Alley from the HHS Office of the Secretary and Kamala Mistry from AHRQ. So we're going to do about, I think, 15, 20 minutes of a Q&A with them, and then we will open it up for questions. Please do feel free, as we're going through this, to share your Q&A, and we will be sure to have a lot of time at the end to discuss your questions. So first, welcome, Don and Kamala. Thank you so much for joining us. You guys, you both have a lot of history and expertise in this area, so I'm excited to engage with you on this. I want to start out with asking you both, kind of just if you could give an overview of the work that your offices / agency are doing currently related to social determinants of health. And Don, maybe we can start with you and then go to Kamala next. Don, if you're on speaking, you're still on mute. You want to unmute yourself on the Zoom as well as on your phone. And maybe we need to unmute you. Well, Don, maybe while you figure out, Kamala, are you able to speak?
I think so. Can you hear me, Caroline?
Yes, we can. So Kamala, why don't you go ahead and give your perspective, and Don will work on technical issues with you.
Kamala should start, but now I'm in. Go ahead, Kamala. No, actually, go ahead, Don, because I was going to kind of piggyback off sort of that HHS perspective. So go for it.
Okay, great. Thanks for your patience. So I want to just start by contextualizing our focus on social determinants and screening for health-related social needs from a department perspective at HHS. So we really see the set of issues that we're talking about in this webinar as critical for value-based transformation. When I say value-based transformation, I'm referring to the larger shift in our healthcare system. We're trying to move away from a fee-for-service system that rewards the volume of care that's provided to a value-based system where ideally providers are rewarded for keeping patients healthy. CMS, the Centers for Medicare and Medicaid Services, has been doubling down across the board to encourage that move to value-based care. There are many examples, and I'm happy to talk about some of them in the Q&A, but a great one is our Pathways to Success, which is Medicare's national ACO program. But we also know that as we ask providers to take on greater accountability for outcomes, they're hungry for tools to be successful in these value-based payment models. They know, and we know, that medical care only accounts for a fraction of patient outcomes, and they're interested in opportunities to address the other drivers of health that are impacting those patient outcomes. And I think that's where some of the overwhelming interest in screening for social needs that Caroline referred to comes in. Now, I just want to briefly mention some of the things we've been working on in the last year and a little bit about what's on deck for us. So to speak briefly about the work at CMS, you all may be aware that CMS recently finalized a number of standardized patient assessment data elements on health literacy, transportation, and social isolation, specifically related to harmonizing those across post-acute care and ensuring that as patients are discharged from the hospital, their social needs are being assessed. On the Medicare Advantage side, we have allowed Medicare Advantage plans to offer supplemental benefits that address health-related social needs for beneficiaries with chronic disease. And what that means is that beneficiaries that are enrolled in a Medicare Advantage plan can now receive services like meal delivery more frequently, transportation for non-medical needs like grocery shopping or home environment services to improve their health or overall function. And then at the CMS Innovation Center with our Medicare Advantage value-based insurance design model, we are allowing participating Medicare Advantage plans there to target some of those supplemental benefits based on income in addition to health status. So that provides another entry point for addressing some of these health-related social needs. We're also continuing, we're now in year 3 of 5 of our Accountable Health Communities model, and we know that there's a lot of interest in those results. Our first evaluation report will be coming out from that later this year, and certainly we and others are learning a lot through the large-scale screening that's been being done through that program in 30 communities across the nation. And we just launched in January the Integrated Care for Kids model in 7 states, really trying to create a holistic system of care for children and their families in Medicaid, and again, addressing this broader set of health-related social needs. CMS is in many ways where the rubber meets the road when we're talking about the move to value and what it looks like to bring social determinants of health into healthcare payment systems. But it's by no means the only place where we are driving progress across the department. Just to provide a few other examples that are more oriented toward research and really building the foundation for the future. The Office of the National Coordinator for Health IT released its draft Federal Health IT Strategic Plan. We can share a link to that with those folks that are on the webinar, but it's open for comment right now and really highlights the need to integrate data related to both health and human services, and to look at capturing and integrating social determinants of health into EHRs, clinical decision support and referrals, and some of the issues that we're talking about here. The National Institutes of Health sponsored a social determinants of health indicator supplement to their Phenotypes and Exposures project, which is specifically oriented toward standardizing data collection protocols for NIH-funded research, with the goal to release a common set of measures that will help researchers collaborate on social determinants of health work. And then the HHS Office of the Chief Technology recently, Chief Technology Officer recently held a roundtable on leveraging data on the social determinants of health, which brought together a large group from across academia, federal, state, and local government, healthcare industry, to look at some of the data gaps and opportunities, including on screening tools and data around health-related social needs. So we've recently released the summary report from that meeting, but I say all of this not to offer you a long list of activities, but just to emphasize that this is an area that, again, we see as critical, and we are trying to take advantage of the evidence that exists today, but also to look at how we can partner with researchers, practitioners, and providers that are in value-based payment models to try to really build that evidence base and drive progress forward. So I'll hand it over to Kamala.
Great, thanks, Dawn. So the work that we're doing at ARC aligns with the HHS focus on value-based transformation and those efforts. We at ARC sort of have 3 main buckets of sort of initiatives. It's data and analytics, research, and then practice improvement. I'll sort of describe a few activities, key activities related to social determinants of health under each. So for data and analytics, we're developing and fielding a social determinants of health self-administered questionnaire, which will be part of the Medical Expenditures Panel Survey, MEPS. And that'll allow us to obtain health and healthcare related information for up to 20,000 adults, focusing on social determinants of health. And so the idea is that this instrument will include specific questions around adverse childhood experiences, ACEs, around housing quality and security, and measures of social cohesion and support, along with other measures. So this is really exciting. MEPS is a very well-used survey, and there's a lot of analytic work done on that survey, and this will be a great addition to that survey. Right now, the instrument is being worked on, and it should be completed in spring of this year, and then fielded in 2021, and then probably publicly available around 2023 for analysis. So look out for updates on that. In addition, recently we had a visualization resource of community health level social determinants of health challenge. And we've had a series of challenges. This one was around social determinants of health to encourage innovation in this area. It was conducted in a two-phase approach, and the first place winner was announced at Health Datapalooza, and it was Mathematica. And they created a community connector tool, which is designed to help local communities and members and policymakers even to understand how social determinants of health are associated with health outcomes. And so it really allows you to examine how your county compares with others in terms of social needs and health outcomes, and really explores intervention areas that might be helpful to improving care and outcomes. And this is available on the Mathematica site if you just look for Community Connector. In addition, we're in the process of developing a consolidated set of national standardized databases on valid and reliable SDOH factors at the small area level and other geographic levels. And this is building on existing databases that are developed by federal agencies. So it's a concerted effort to sort of bring things together from different federal agencies. And this is, I have to say, in its early stages, but you know, we're working forward on that. In terms of practice improvement, which is another main area of focus for us, ARC has recently funded a group of grants that are working on innovative dashboards that really leverage cross-government and community data to enable primary care providers to target interventions to address SDOH. And that includes homelessness, hunger, to prevent and manage chronic conditions. And these grants are underway, and we hope to see results of those grants out and available in the next few years. In addition to that, building on some of what Don was speaking about in terms of e-care, ARC and NIDDK at NIH have partnered to develop comprehensive interoperable electronic care plans, or e-care plans, for people with multiple chronic conditions. And this will enable patient-centered data to move across home, community, clinic, and research-based settings. And it will include a number of social determinants of health data elements. And so the e-care plan is really allowing us to leverage longitudinal standard-based blueprints, but also incorporate individual patient-level social determinants of health data points. And then lastly, I really want to focus on research, which is the main area here at ARC, and want to highlight a special emphasis notice, which aligns again with the value-based transformation efforts that Don highlighted. But one main area of focus in the special emphasis notice is social determinants of health. So there are a number of specific areas under number 4, which is prevention of disease, that really focus on addressing social determinants of health. And I would just kind of flag this, and I want to just review that a special emphasis notice is kind of ongoing, and it overlays on existing standing R18s, R03s, other broad R mechanisms for funding. And it also, this SEN overlays on career development awards. So I hope you'll get a chance to look at that. So with that, I think, Caroline, I'll hand it back over to you.
Wonderful. Thank you both for providing that great summary of what is happening in various parts of HHS. Building on that, and with a focus on research, what do both of you think are the most pressing research needs from your perspectives? We'd really love to get a sense of kind of what are the areas where federal action feels like it's being slowed down because the research is not there yet. I don't know if one of you wants to go first, or we can go in the same order.
I mean, I think we addressed some of these issues, of course, in a long list of questions that were in the paper, but there's a very basic question about what works for whom. And I would define that from a value-based payment perspective as where do these screening tools generate value or related interventions generate value in terms of either reducing cost and improving quality, or at least being cost neutral and quality improving. And I think we know a lot about what some of the promising practices are, but don't have a great sense yet at what this looks like at scale. Lots of questions about targeting and the right balance between thinking about more systematic population level approaches, even if that population is defined as all patients visiting a given provider versus, for example, a geographic definition, but versus much more targeted approaches focused on, you know, individuals that have a combination of, for example, utilization history and specific health-related social needs. So I think we see a growing use of this data as we have more of it about what the sort of health-related social needs portfolio looks like, but have much less information about what the right interventions are to address it.
So I'll follow on that. I think from our perspective, I think it's important to, I most think of this as a continuum of research. And I think, as Don pointed out, we really need to focus on, you know, furthering knowledge on what works and how it works. And I think of this as more of the kind of underlying evidence base. But I think from, you know, our perspective, that it's also important that we should be learning more about how to implement this knowledge, thinking about scaling, as you know, we discussed in that paper. So this idea of really thinking from evidence generation to implementation science, and really thinking about what's important when we're on the ground actually doing this work. And I think this allows for a more comprehensive approach to addressing the research needs around social needs intervention research. One area I would just point out that we didn't expressly or explicitly sort of call out, but I think is really important, and probably Don and Caroline, you'll agree, is this kind of focus on standardization. I think in the work that we're doing at ARC, and I think across HHS and more broadly in the field, you know, I want to highlight that there's a real need to increase standardization around tools in terms of and also in terms of how we think about outcomes. And I think this will allow us to do comparisons across studies, and I think it's central, and a lot hinges on that, and it's an important focus of, you know, this area of work as we move forward. It's important for screening, but also in terms of intervention work. So I think that's a very important and pressing area as well.
Great. So what do you guys think is needed to accelerate knowledge development? Don, you want to go first?
Yeah, I think that we are seeing just such an explosion of research in this area, and that gets back to Kamala's point about standardization. It's really exciting to start seeing some of these results come out, but it's going to continue to be hard to see, you know, kind of get head-to-head comparisons across different populations or clinical contexts without some greater degree of standardization. So I think that's probably one of the biggest areas. And then I think continuing to really make sure that the research that's being done builds on the provider perspective and the patient perspective. I think the folks that are really doing a lot of this work know just how important workflow is as we think about what the screening looks like, what potential referrals and interventions look like. And so if we want to learn what works in a scalable way, making sure that we aren't, you know, doing research in a kind of isolated context that is not going to be repeatable in other settings across the country will be really important. Kamala?
Yeah, so I agree with all of that, and I would just say I wanted to highlight I think it's table 1, Caroline, is that right, in the paper, but really sort of our focus and thinking about the underlying sort of mechanisms. And I think if you think about evidence generation, I mean, so much of the success of the models and the work that we're doing broadly in this area, interventions and, you know, the payment models really hinges on this sort of underlying evidence base. And so I think that, you know, we really, really need to be thinking about that and examining that critically and thinking about, we put forward and hypothesize on some of those mechanisms, but really, in addition to really thinking about, you know, on the ground context, as Dawn pointed out, really try to bolster our evidence, you know, around those mechanisms and those models so that, you know, we're confident or more confident that the work that we're doing is sort of based on a logic model or an underlying conceptual framework that makes sense. So yeah, I would add that.
Great. Well, thank you both. We have a lot of questions that have come in. So I'm going to switch us to answering all of your questions, or try to answer as many of them as possible. So one of them that has been kind of upvoted by a number of people is a question about what's the point of asking about social needs if no assistance can be offered? And also, wouldn't that be kind of unethical? And I think that is a question that a lot of people are asking themselves. And one of the things that we did want to highlight in the paper, I think with that mechanism pathways table that Kamala mentioned, is the fact that there is some evidence beginning to accumulate that, as I mentioned a little bit earlier, patients actually may really appreciate being asked about these needs, because it makes them feel like their care team or their provider is understanding their lives better and cares about their life, so it makes them feel a little bit better taken care of. Again, this is fairly minimal evidence on this so far, so it's definitely an area that merits more research. I think the other reason that was articulated by the National Academy's report last fall, and I encourage any of you who haven't seen it to go and look at it, is that this information is crucial information for anybody that's providing care to somebody who's facing social economic needs, because it has implications for the care plan. As a provider, you're going to put together a different care plan for someone if they're facing food insecurity than if they're not, if they're at risk of being evicted than if they're not, et cetera. So it's just good medical care and to be aware of these needs. So I think those would be kind of the two things that come to my mind in thinking about the point of asking about social risks and needs, even if there are no services that can be offered. Dawn and Kamala, is there anything you want to add on that point?
I would just, you know, add to that, you know, I think that this is still an area, I think we highlighted in the paper, and I think Laura and I think Karen and Nancy in their sort of article also highlight that this is an area that we need a lot more work in terms of thinking about, you know, patient acceptability of social risk screening. And while I think we, as Caroline pointed out, we're starting to see more evidence in this area, I think that it's really, really important. And also just taking, you know, a patient-centered approach, as Dawn noted when she was speaking earlier as well. So I think we have to, keep that in mind. And also, I think this piggybacks on this idea of, you know, unintentional harm or consequences. And so I think, you know, that's something we wrote about in the paper, and I think it's important to kind of think about when we think about this as well.
Great, and actually that's a great segue to another question that came in related to unintended consequences and potential harm. Someone said, can you say a little bit more about that? I can take a quick first stab at that, since I had mentioned it earlier. So I think there's some concerns that patients could feel stigmatized, but either if the screening is done in such a way that it targets only certain patients, Patients may feel stigmatized that way, or I think there's some concerns that patients have that if, who knows this about me, and how will that affect the care that's provided to me? And also, I think some of the research that Siren has done suggests that patients may be comfortable maybe with their physician knowing this, but maybe less comfortable with this being information being put in the electronic health record, a little bit less comfortable with the idea of a larger number of people knowing. I think some of the other negative unintended consequences that you mentioned, Kamala, is, this is adding one more thing to the really already very, very busy plate of providers and care teams. And is this going to potentially increase burnout? The hope is that it wouldn't, but that's definitely something that needs to be examined. And then there's the question of what's the impact of this more generally on also the social services sector. We're seeing some research come out that suggests that in general, a number of CBOs are seeing this as both a potentially good thing and a potentially negative thing. So on the good side, that this could present an opportunity for having healthcare organizations pay for services that CBOs provide, so an additional source of funding for a social service sector that often is underfunded. On the flip side, CBOs are concerned that the kinds of things that healthcare organizations may expect them to do would limit the interventions that they can provide, that would lead to kind of a really narrow focus on only things that are related, for example, to high healthcare utilization, as opposed to really taking an approach that is about what the patient or client needs. So those are the kind of negative consequences that people are thinking about in terms of the CBO sector. Dawn, Kamala, anything you want to add on that side?
This is somewhat distinct from that, but I know I've seen a couple of questions pop up about the CBO sector, and there is so much that we could say there. I do want to put out a plug for a health affairs blog post that just came out today from the SCAN Foundation and the Administration for Community Living about opportunities to utilize CBO network models and to build CBO capacities to contract with health plans and providers that are taking on greater financial risk as part of value-based payment. This is an area that we are thinking about a lot, and we have certainly a lot of lessons learned from work that we've done coming from the healthcare side and working in various ways to directly pay for healthcare services that are provided by CBOs or contract with CBOs. And I think we see that as a really critical national infrastructure that we have to figure out how to support and take advantage of as part of this transformation. So again, I would point to that post. And I know we've also seen a number of questions about sharing some of the resources that we are referencing. And I think we are planning to do a follow-up email with links to some of those. Is that right, Caroline?
Yes, absolutely. Great. There have been a few questions coming in specifically about Z codes and data sharing, et cetera. So that's definitely an area that there is a lot going in on. I think somebody asked about Z codes specifically. There was just a CMS report that came out last month, I think. You can find it in the most recent Siren newsletter, the February newsletter, that found that I think it was 1.4% of Medicare fee-for-service claims in 2017 had Z codes associated with them. So while there's, I think, great interest in Z codes and coding in general to help facilitate collection and use of data, I think there's still a lot of room for growth and use of those. I will point folks who are interested specifically in this issue to a project called the Gravity Project, and we'll include that in the resource that we send out afterwards. It's a national collaborative consensus development project that Siren helped start, but that is now much larger than us, focused specifically on the issue of standardizing coding of social determinants of health data to maximize interoperability. So anybody interested in that, please follow up on that. Dawn and Kamala, anything you want to say on the kind of coding side of things?
I think you did a great job, Carol.
Great. There are some specific questions coming in that might be worth highlighting. So Kamala, one person was asking, there are several social determinants of health screening tools already in use, including the HC model tool. So the question was, why work on developing another self-administered survey? It seems important to move towards standardization of screening. I think that was your point, but do you want to just kind of highlight that a little bit more?
Yeah, I think we do. We're in the work that we're doing in terms of the self-administered questionnaire. We worked really closely with CMS on trying to connect those with standardized instruments that they're using also as part of the CMMI models. But in addition, I think the idea is really to have this linked to the broader MEPS medical expenditures panel survey, so that I think it provides these variables in addition to a number of other variables that look at cost and utilization. So I don't know if that helps or that answered the question. I hope so.
Thank you. Yeah, and there are a number of questions and comments, I think, related to the issue of, what we talked about in the paper was really individual focused interventions, focusing on individual level social needs. Individual social needs are obviously kind of an individual level manifestation of larger social conditions. And so there are a lot of questions around the interface between these individual level, patient level interventions and more community level efforts. I think our paper didn't specifically focus on that, so I want to just acknowledge that's part of why we haven't highlighted that much as part of this webinar so far, but it is clear that that's a huge part of what is happening in this space as well. In the National Academy's report, they highlighted, they used a framework that involved highlighted 5 different categories of activities that health sector can do related to social needs. And the first one was awareness related to screening. The second one, this idea of adjusting care, tailoring care. The second one was assistance, so helping people with addressing needs. And then the last 2 were advocacy and alignment that are about community level intervention. So there's definitely, I think, an awareness at a national level that is part of this. I think where I might suggest that there's a lot of gaps still in understanding how individual level interventions and community level interventions can best intersect. There was a great example that somebody wrote in the Q&A of how identifying needs among patients helped target community level interventions, I think, on homelessness. So I think that's a good example of the kind of interaction between individual level identification of needs and community level work. But there's definitely a lot going on there. I know as part of the AHC model, Dawn, you may want to mention or talk about, the fact that the AHC model envisions a community level piece as well. Do you want to highlight that?
Absolutely. Yeah, so the AHC model, CMMI's Accountable Health Communities model, has 2 tracks. The assistance track, which was focused on testing in a randomized design the impact of community service navigation to address health-related social needs that are identified through the kind of standardized screening that we're talking about, as well as the alignment track, which was intended to bring together organizations at the community level, including healthcare delivery, clinical sites, community-based organizations and social services, local government, and local payers, with a kind of community quality improvement approach to try to look at all the data that's coming out of this work, and with an eye toward improving alignment to address the identified community needs. I think we're still too early to have a great sense of the extent to which that is working as designed. But I think one thing that we have seen is the power of that data. So as one example, we have an accountable health community site in Hawaii, and the Hawaii Medicaid director said, we really thought that housing was going to be the biggest issue, but we were surprised to see the amount of food insecurity, and that was, at least at that site at that time, the top most frequently reported need. And so I think we are seeing how that granular data is helping to drive at least the recognition of the areas that we need to focus on, and it remains to be seen the extent to which that is able to actually catalyze better alignment to meet those needs at the broader community level.
Great. There was a question in there, Don, again, going to you about saying a little bit more about the Medicare Advantage supplemental benefits. Could you just say a little bit more about what the expansion was there?
Yes. So I'm happy for us to share some resources about that. And actually, Siren did a great webinar on this a couple months back. But there are a variety of flexibilities now through the Medicare Advantage program, allowing plans to, as part of their supplemental benefits, include services to address social needs. Those could be things like services to address food insecurity. I think food and transportation are the areas that we are seeing the most work, although there is a lot of flexibility. And then those plans, so that is an option that is available for all Medicare Advantage plans. We have a specific model test that allows plans to target those supplemental benefits based on income versus just healthcare status, or excuse me, versus just health status. That model test is the value-based insurance design model test, and happy to include a link to that in our follow-up materials.
Great. There's also a question in here about how are how is HHS kind of working with other agencies like HUD, USDA on some of this work, and do you think that the research gaps are viewed similarly in those agencies to the extent that you have a sense of that?
So we work with HUD and USDA regularly. I think one thing that is really promising and exciting is that there is a strong interest in those kind of multi-department collaborations, and a growing understanding of the touch points and synergies. To offer one concrete example, HUD has been doing quite a bit of work around supportive housing and integrating services into housing for older adults in particular. And that is an area where there is a lot of thinking and evaluation happening across departments. So I think there is the groundwork for these kinds of multi-sector collaborations to address the full spectrum of causes of poor health. I will also note that it is challenging, certainly given conflicting statutory requirements for different agencies, conflicting eligibility requirements at the individual level, to follow one minute point about that integration across housing and services for older adults. The definition of older adults is different in HUD programs versus CMS programs versus Administration for Community Living programs. So those are areas that we're acutely aware of, but it is always helpful for us to hear from stakeholders about the particular pain points that are making it most challenging to make progress on the ground as well. So I hope that's helpful.
Yeah. Kamala, anything you want to add on that topic?
No, I would just say, I think over the past few years under the value-based transformation initiative, I think we've seen a lot more collaboration. Dawn, I think you would probably echo that. And I think it's really allowed us to leverage, data across HHS and also look at, strengths and weaknesses. Sometimes we're collecting information in the same areas, and I think it's allowed us to sort of compare and contrast and strengthen the overall data infrastructure. So I think it's been, I'll just sort of feed into what Dawn was saying there.
Great. I'm wondering, somebody asked a question specifically around kind of transportation and kind of how transportation barriers are often viewed specifically in the lens of barriers to accessing healthcare, but obviously transportation as a whole is an important social determinant of health. There's a question generally about tools that capture that broader agenda. Anything that either of you guys want to speak to on that? And I'm happy to fill in stuff afterwards too.
I would just note that explicitly in the design of the Accountable Health Communities model, we were very specific about the fact that we wanted to assess transportation needs not confined to healthcare transportation. So I think that is one tool to check out, but I totally agree with the comment and the need for a broader definition.
Yeah, and I will add that we just published a review of healthcare-based transportation interventions. And so far on the research front, I think we found just one study that was looking at transportation more broadly, not just medical transportation. So I think that this is one of these places where, as a general statement, I think that this work has, as several have noted on the list, has a fairly health-centric view of things, the work that is happening kind of from a clinical lens. And so I think that has been the first place that people have gone, but I would not be surprised to see more interventions that are taking a broader lens as we go forward. So I think that's something to be interesting to keep an eye out for. Great. I think in our last few minutes, I might want to highlight a little bit. There's a few questions that have come up around capacity building and kind of what are some resources for capacity building. I would point folks, I want to, maybe turn it first to Kamala and Dawn for your thoughts around capacity building.
This is really challenging. It's certainly an area that we are, investing in and testing in the Accountable Health Communities model. But I would say that this is a challenging area for CMS in particular, in that CMS is primarily a payer. And so this is a place where I think we have to really look at all the resources that are already out there or that other parts of the agency can bring together. Certainly CDC has done a tremendous amount of work on local capacity building as it relates to public health as one example. So I think this is where, to a certain extent, it takes a village, and this is an area where we are learning alongside all of you. Kamala?
Yeah, I would agree with all of that. I think there are a number of resources through HHS, CDC, ARC that I think focus more on the data aspects, but I think there's many aspects through, in terms of capacity building. And I would just highlight that that's an area of interest for research in terms of ARC's priorities and thinking about capacity building, and also thinking about the role of partnerships and where we could sort of reinforce and support each other in terms of health system work with communities and vice versa in terms of building capacity. So.
Great.
And I just want to note, I know we're just about out of time. I think there are really nuts and bolts elements of capacity, including capacity for partnerships and a lot of technical and community-oriented work that has to happen there. I also do think that data can be an important first step. And to answer another question that came up, can create champions in all sorts of organizations. I think one thing we've seen, I'll offer one example. We were visiting a primary care practice, primarily a Medicare practice, not a lot of Medicaid patients, or low-income patients, and they had said, you know, we'll do this screening thing, but we don't think we're going to find much. And they were blown away by the amount of food insecurity, by intimate partner violence, all these things that they thought they had to read on in their patient population, and then came away with a much better understanding of the opportunity to serve their patients better, and they became champions for those approaches. That's a very clinical example, but I think that's something that we see over and over again, is where we can provide data that really highlights the gaps. There are community level champions that are motivated to try to fill them.
Well, Dawn, that's a great place to end. Thanks to both of you for participating in this webinar. Thanks to all of our panel attendees. Thank you so much for your questions. I'm sorry we couldn't get to all of them, but we will send as many resources as we can in response to those questions in our follow-up email. And I just want to mention that we are going to do a webinar on the Camden Coalition RCT in April. There were several questions on that, so stay tuned for that. Thanks again so much, and have a wonderful rest of your day, everybody.
Thank you.